Good day everyone, we are BSN 3E Group 5 and today we will be discussing the Neurovascular Assessment, Pupillary Assessment, Glasgow Coma Scale, and Cranial Nerve Assessment. The CLO or Course Learning Outcomes for today are CLO number 1, define the key terms in Neurovascular Assessment, Pupillary Assessment, Glasgow Coma Scale, and Cranial Nerve Assessment. CLO number 2 are to discuss the importance and indications of neurovascular assessment, pupillary assessment, Glasgow Coma Scale, and cranial nerve assessment. CLO number 3 is explain the parameters and method of exam and interpretation of results in neurovascular assessment, pupillary assessment, Glasgow Coma Scale, and cranial nerve assessment. CLO number 4 is identify the guidelines in using the tools for neurovascular assessment, pupillary assessment, Glasgow Coma Scale, and cranial nerve assessment. For CLO number 5, it is to distinguish between the normal and abnormal findings. CLO number 6 is to discuss briefly the physiology of pupillary reactions and the different levels of consciousness. CLO number 7 is to compare and contrast the adult and pediatric Glasgow Coma Scales. CLO number 8 is to examine the nursing responsibilities before, during, and after using the different assessment tools. And lastly, CLO number 5 is to demonstrate beginning skills in evaluating a client's health status using the various assessment tools. Good day everyone, I am Gail Afra Cilarino and today I will be discussing the neurovascular assessment. The CLO1 is to define the key terms in neurovascular assessment. Neurovascular assessment is the assessment of peripheral circulation, motion, and sensation of the affected extremity, assessing the fingers or toes of those affected extremity and comparing them with those of the opposite ones. This involves the evaluation of the neurologic and vascular integrity of a limb through a system assessment of any neuromuscular deficit, which can allow for appropriate treatment. Next is the compartment syndrome. This is the most serious complication of casting and splinting. Compartment syndrome occurs when increased pressure within a confined space compromises blood flow and tissue perfusion. Examples of confined space would be cast or muscle compartment. The earliest indicator of developing compartment syndrome is pain that seems out of proportion to the underlying injury and pain on passive stretch of other muscles in the immobilized limb. Compartment syndrome also occurs more frequently in young adults, and although it may take up to 48 hours for symptoms to be present, it typically develops quickly and within 6 to 8 hours after the initial injury or after fracture repair. Paresthesia is the abnormal sensation of tingling or numbness or burning. This is also called the pins and needles sensation. Paresthesia is an early sign of nerve involvement. CLO2 discusses the importance and indications of neurovascular assessment. So the purpose of neurovascular assessment is to assess for compromise of nerve function and circulation, to prevent damage to tissues of affected area, to detect early signs and symptoms of possible neurovascular compromise, and lastly, for early recognition of diminished circulation and nerve function to prevent loss of function. For CLO number 3, it is to explain the parameters and the methods of exam and interpretation of results in neurovascular assessment. So for the indications for neurovascular assessment, patients who should be assessed include but not limited to musculoskeletal trauma to the extremities such as limb fracture, crush injury, dislocation, and deep lacerations. Patients with limb fractures, crush injury, and dislocations are in an increased risk for acute limb compartment syndrome or ALCS, which would indicate for a neurovascular assessment. Musculoskeletal trauma could impede blood flow to the injured extremity and affect nerve function, which is why the assessment is necessary. It is also indicated for post-operative surgeries such as internal or external fixation or fractures, orthopedic surgery, spinal surgery, plastic surgery on extremities or phalanges, cardiac catheterization, and tourniquet applied for long periods. Post-operative pain can be distinguished from compartment syndrome pain, as compartment syndrome has its own pattern of pain. Post-operative patients are indicated for the neurovascular assessment, as there could be a nerve disturbance that occurred during the surgery. Assessment for paralysis, pain, or pulse is necessary to assess blood flow and nerve function. Other indications would be application of plaster, traction, back slab, restrictive dressings, splints, or casts, also known as restrictive dressings. Application of a restrictive dressing to stabilize a fracture could lead to compartment syndrome, so a neurovascular assessment is necessary to assess any onset of the syndrome. Application of traction on skin or skeletal is also indicated. If not monitored, compartment syndrome could arise so a neurovascular assessment is needed. Burn patients are also indicated specifically for circumferential burns. Burn patients are indicated for the neurovascular assessment, as the degree of the burn could affect the nerve function of the extremities, and the assessment for blood flow and nerve function is necessary to prevent the burn area from necrosis. Signs of infection in the limb is also indicated. If the infection of the limb is complex, nerve function and blood flow could be compromised, so a neurovascular assessment is needed to assess for peripheral circulation, motion, and sensation. Spinal injuries are indicated because spinal injuries could indicate paralysis is present, so a neurovascular assessment is needed. Vascular injuries could indicate nerve damage and blood flow obstruction, so a neurovascular assessment is needed to assess peripheral circulation, motion, and sensation. Trauma or surgery to limb or joints is indicated, and any report of altered sensation is also indicated. Altered sensation could indicate an abnormality in peripheral circulation, motion, and sensation. Underlying comorbidities are also indicated, for example, tumors. In the case of tumors could obstruct nerve function and blood flow, which could cause peripheral circulation, motion, and sensation to be affected. And lastly, tendon, artery, nerve repairs, or splint skin grafts. Grafts has a chance of being rejected, which means that the grafted body part is not properly functioning, which will cause the peripheral circulation, motion, and sensation of the body to be damaged. Any injury that could indicate nerve damage would actually permit for a neurovascular injury. There are multiple parameters for neurovascular assessment. The mandatory parameters for assessment include the basic 5 P's, which are the pulse, paresthesia, pallor, pain, and paralysis, though there are also times where the poikilothermia and edema are also assessed. There is no specific order to the assessment, but it is recommended to follow the same order each time so that nothing is missed. For pulse, assess upper extremity peripheral pulses and lower extremity peripheral pulses bilaterally. The peripheral pulses are assessed to determine the blood flow to the legs. Examples of the upper pulses to be assessed are the brachial, radial, and ulnar pulses, and the lower would be the femoral, popliteal, posterior tibialis, and dorsalis pedis. The posterior tibial pulse can be found approximately 1 inch below and behind the medial malleolus at the inside of the ankle area. As the artery here is deeper, concentration is needed to feel the pulse. The dorsal pedis is located approximately between the second and third digits at the middle of the foot. The dorsalis pedis is anatomically absent in approximately 10% of the population, so its absence should be noted in every routine handoff. Also, be sure to assess for the presence of pulses distal to any injury. Feel the pulse by applying easy pressure using the pad of the index finger and middle finger. Use a 0 to 4 point scale, noting if the pulse is weak, diminished, or absent. So if the score is 0, that would indicate absent or no palpable pulse. If it's 1, it is weak, barely palpable, or easily obliterated. And 2, palpable. 3, strong and easily palpable. And lastly, 4, bounding. Use a marker to indicate a pulse palpation site that is difficult to locate. This can help others with their assessment and provide consistency. If a pulse palpation site is challenging to find or if the pulse is weak, use a manual Doppler scan. If palpable pulses are not accessible due to casting, assess all other parameters. A decrease of a pulse or a loss of a pulse is a critical finding and must immediately be told by the physician. Additionally, document if a change in the pulse is detected and notify the appropriate healthcare provider. Assess the capillary refill time by pressing on the nail, releasing, and note the pinkish tinge on the nail bed, which should be 3 seconds or less. If the patient is post-surgical or post-injury, check the pulse on the unaffected side first, then the affected side, and compare. The next parameter is paresthesia. First, ask about altered sensation on the affected limb. Sensation should be numbness, tingling, or pins and needles. Okay. The next parameter is paresthesia. First, ask about altered sensation on the affected limb. If paresthesia is present, numbness, tingling, or pins and needles are detected. Ask the patient about changes in sensations such as tingling, numbness, pressure, or burning. A pressure sensory exam often consists of assessing light touch with a cotton swab and assessing temperature discrimination with warm and cold stimuli. Next would be pallor. Observe the color of the limb and compare the color of the skin bilaterally, noting any difference in appearance. Consider the patient's usual skin tone and any skin conditions when performing this assessment, as cyanosis can present differently in different skin tones. Pallor or cyanotic could indicate inadequate artery supply, and dusty, cyanotic, mottled, or purple-black coloration may indicate inadequate venous return. Next is pain. Determine the amount and severity of pain along with the areas of radiating pain. Ask the patient to describe the pain and ask for the location and characteristics of the pain. Ask for descriptions while avoiding coaching the patient which words to describe the pain. If the patient is intubated, unconscious, or otherwise unable to communicate their pain, the assessment will rely more on the other components. Pain is assessed by asking the patient to rate pain on a scale from 0 to 10, with 0 the weakest and 10 the highest. Ask the patient to indicate the exact site and to describe the character and intensity of the pain using a pain rating scale. Assess the pain score at rest and on passive stretch, as well as whether the pain is disproportionate to the injury. Be aware of nonverbal pain cues, and in sedated patients or those who can't verbalize information, be aware of nonverbal cues such as grimacing, guarding, tachycardia, and hypotension. Any compromise to neurovascular status will result in pain due to sensory nerve damage and diminished blood flow. Next is paralysis. For paralysis, assess range of motion and strength. The patient's ability to perform specific movements is a key indicator of motion function of specific nerves. For a sensory assessment, ask the patient to close their eyes and using touch, assess the sensation in the dorsum and medial areas of the foot along with the tips of the toes. Move the hand up each leg to determine if the patient is able to feel the touch. Motor function is tested with the patient's eyes open and ask the patient to wiggle their toes and then plantar flex and dorsiflex each foot while the nurse provides resistance with each hand. The inability to do plantar flex or dorsiflex could indicate a neural deficit that could lead to a foot drop and should be reported immediately. Loss of function is often a late sign of neurovascular compromise. Also note that nerve block or epidural in surgery could show a loss of sensation and/or motion that would not be abnormal to the situation. Next is poikilothermia. This is the assessing of the temperature. Use the back of your hands to assess the skin bilaterally to assess if the skin is warm, hot, cool, or cold. Compare one to the other. Skin should be warm to touch normally, so cool skin may indicate inadequate arterial supply and warm skin may indicate inadequate venous return. Lastly is edema. Edema can result from musculoskeletal injury. Inspect the toes, foot, and leg for swelling and compare the two sides. Note if there is an increase since the last assessment and monitor for any changes. Also note if there is pitting edema. This can contribute to neurovascular compromise, which can then cause damage to the muscle and nerve tissue. A limb will generally appear tight and shiny if compartment syndrome is present. Pre-existing disease processes can place a patient at increased risk for edema-related complications, and examples are heart failure, cirrhosis, or kidney disease. Lastly, elevating the limb can help decrease the edema, but should not be higher than the heart level. Next would be CLO number 4 and 5. CLO number 4 is to identify the guidelines and using the tools for neurovascular assessment, and CLO number 5 is to distinguish between the normal and abnormal findings. Guidelines. First, inform the patient that the assessment is painless and non-invasive. Provide clear instructions and assist the client in performing some of the simple range of motion exercises. Always check the contralateral limb first. Assessment needs to be performed in full light and use a separate form for each limb which is being assessed. Ensure the correct form is used for the affected limb. Check peripheral pulses as well as the capillary refill response, edema, and the color and temperature of the skin when assessing the peripheral circulation. Note any signs of weakness or paralysis of the injured body part when assessing motion. Monitor for paresthesia or absence of feeling in the affected extremity, as it could indicate nerve damage when assessing for sensation. Normal and abnormal findings. The normal findings are the ones that indicate that nothing is wrong with the neurovascular system of a person. The abnormal findings, however, can indicate a neuromuscular deficit or an abnormality in peripheral circulation, motion, and sensation that is caused by an injury. The inability to detect an abnormal finding could lead to a worsening condition of the patient. Delays in treatment could lead to serious outcomes. The parameters are pain, pulse, paralysis, paresthesia, pallor, capillary refill time, and temperature. In normal findings for pain, no pain is felt, though the abnormal findings for pain is that pain is felt and present even with passive motion. Normal findings of pulse is that pulse is present and strong are approximately 60 to 100 beats per minute in a normal adult. For an abnormal finding, pulse is weak. For paralysis, normal finding is that limbs can fully move both arms, capable of performing simple range of motion exercises. Abnormal findings for paralysis is has difficulty or is incapable of performing simple range of motion exercises. The normal findings for paresthesia is can feel light touch in extremities and responsive to stimuli. Abnormal findings for paresthesia is diminished sense of touch, numbness, or tingling. Normal findings for pallor is pink or redness present and skin is warm. Abnormal findings would be purplish, bluish discoloration, blotchy or dark in color compared to original skin tone. Normal findings for capillary refill time is 1 to 2 seconds, and abnormal findings is more than 2 seconds. Normal temperature in adults is 36.5 to 37.5 degrees Celsius, so abnormal findings would be less than 36.5 degrees Celsius or more than 37.5 degrees Celsius. Other parameters are color, temperature, and capillary refill time. Normal for color would be pink, normal for temperature would be warm, and normal for capillary refill time would be 1 to 2 seconds. If the color is pallor or white cyanotic, this could indicate inadequate arterial supply. If the temperature is cool, it could indicate inadequate arterial supply, and for capillary refill time, if it is more than 2 seconds, this could also indicate inadequate arterial supply. For color, dusky, cyanotic, mottled, or purple or black coloration could indicate inadequate venous return. Hot temperature could indicate inadequate venous return, and rapid capillary refill time could indicate inadequate venous return. This picture is an indication on how to do the neurovascular assessment. These are the normal findings for each nerve. So for the peroneal nerve, the normal indication would be feeling pressure at the web space between the great toe and second toe for sensation. And for motion, the patient is able to dorsiflex the ankle and extend toes at the metatarsophalangeal joint. The normal findings for tibial nerve for sensation would be feeling present on the medial and lateral surfaces of the foot, and the normal finding for motion would be have the patient plantar flex ankle and toes. The normal finding for sensation for radial nerve would be feeling at the web space between the thumb and index, and for motion, have patient hyperextend thumb, then wrist, and hyperextend the four fingers at the metacarpophalangeal joint. The normal findings for sensation and motion for the ulnar nerve would be touch the distal fat pad of the small fingers, and then for motion, have patient abduct all fingers. The median nerve normal findings for sensation would be feeling at the distal surface of the index finger, and for motion, have patient opposed thumb.
Good morning. My name is Renee Esmania, and I will be reporting about pupillary assessment. After 1 hour of class discussion, the Level 3 students will be able to, first, define the following terms: direct light reflex, concentric light reflex, and anisocoria. Second, discuss briefly the physiology of pupillary reactions. Third, identify the purpose of pupillary assessment. Fourth, explain pupillary assessment as to its indications, guidelines, and normal and abnormal findings. Definition of terms. First is direct light reflex. This is when you shine your pen light over one eye and the pupil of the same eye constricts. Next would be consensual light reflex. So if you are shining light over the right eye, consensual light reflex is the constriction of your left eye, and vice versa, if you shine light to your left eye, a consensual response is the constriction of your right eye. Next is anisocoria. It is a condition characterized by an unequal size of pupils. It is often harmless but can be a sign of a more serious problem. There are three types of anisocoria: physiological, mechanical, and pathological. Physiological anisocoria are pupils that are naturally different in size of no more than 1 millimeter difference. Mechanical anisocoria is a result of physical damage to the eye, such as an injury that caused inflammation to the eye. And pathological anisocoria is when it comes from a disease or condition such as brain hemorrhage or aneurysm. Next is the physiology of pupillary reactions. The physiology behind a normal pupillary reaction is a balance between the sympathetic and parasympathetic nervous systems. Parasympathetic innervation leads to constriction, while sympathetic innervation leads to dilation. A circular muscle called the sphincter pupillae has a task of constricting the pupils. It all begins at the Edinger-Westphal nucleus when it is stimulated by the pretectal nuclei. Then the Edinger-Westphal nuclei generates action potential through the cranial nerve 3 nerve fibers and ultimately synapses at the ciliary ganglion, thus constricting the pupils. Dilation is controlled by the dilator pupillae. Sympathetic innervation begins at the cortex with the first synapse at the ciliospinal center. Postsynaptic neurons then travel to the superior cervical ganglion, then through the carotid plexus, then to the long ciliary muscles, thus allowing the dilator pupillae to dilate the pupil. Next is the purpose of pupillary assessment. The purpose of pupillary assessment is to measure and compare size of the pupil for detecting anisocoria or any abnormalities. To measure and compare shape of pupil related to trauma, surgery, and/or inflammation of the eye. Lastly is to assess pupils' reaction to light and accommodation to detect any abnormalities in the function of the iris, optic nerve, and visual pathway. Next is to explain pupillary assessment as to its indications. First is to assess the function of cranial nerve 3 or oculomotor nerve and to early detect disorders or abnormalities. There are circumstances where a person thinks his or her pupils are naturally unequal or naturally different, but that is not always the case. Therefore, undergoing pupillary assessment is a sure safe for early detection of any abnormalities. Third is uneven sized or shaped pupils, and fourth is pupils not reactive to light and accommodation. Usually the pupils in each eye dilate or constrict at the same time. When they do not, the pupils may appear to be different size or shape. This term is called anisocoria. Next is guidelines or nursing responsibilities. Before, make patient sit comfortably on a chair or edge of the bed. Explain the procedure to the patient. Remove any glasses or contact lenses if client has any. Dim the overhead light source and don gloves. During, have a patient fixate a distant target in the room before measuring the pupil distance. Place the ruler on a supraorbital ridge and position it so that half the pupil is covered. Warn patient before shining the pen light on his or her eye. Avoid shining the light in the other eye to observe the consensual reflex. After, document the findings and do aftercare. Next is findings. For the normal findings, pupillary distance between 58 to 68 millimeters, generally equal in size and round-shaped. They constrict to direct response and consensual response. Pupil dilates in the dark. For abnormal findings, unequal in size pupils, or also called anisocoria, oval-shaped pupils, which may indicate an elevation in the intracranial pressure, defected direct response, which may indicate a lesion pressing against a nerve preventing any response in that same eye, defected concentric response, which may indicate a lesion pressing against a nerve preventing any response in the opposite eye. Constricted pupils are also called miosis, which means excessive constriction of your pupil. And when your pupils are excessively dilated, which is also called mydriasis. The size of our pupils are controlled by two counteracting muscles, dilator pupillae and the sphincter pupillae. Usually, miosis and mydriasis is caused by a problem with either of your iris muscles or the nerves that control them. Miosis and mydriasis are not conditions themselves but are symptoms. If these symptoms persist, then the underlying cause may range from less serious, such as medication side effects, to more serious, such as brain trauma or nerve damage.
Glasgow Coma Scale to be reported by Ms. Loga and Ms. Magallanes. Define the following terms: aphasia, apraxia, decelerate, and decorticate. Number 2. Present the purpose of Glasgow Coma Scale assessment. Number 3. Describe the different levels of consciousness. Number 4. Discuss Glasgow Coma Scale assessment as to its indications, limitations, normal and abnormal findings, adult Glasgow Coma Scale, and the pediatric Glasgow Coma Scale. CLO number 1. Define the following terms. Number 1 is aphasia. It is a language dysfunction impacting speech output or understanding and reading or writing ability. It is usually because of brain damage and most often from a stroke, especially in older adults. So here are the symptoms of aphasia. We have trouble speaking clearly, trouble understanding speech, trouble in writing clearly, trouble understanding written words, trouble remembering words, and remembering object names. Number 2. Apraxia. It is a neurological condition marked by a lack of capacity to perform well-trained movements and actions, including a willingness and physical ability to perform them. It results from brain dysfunction, particularly the parietal lobe, which can be caused by several diseases or brain injury. Number 3. Decelerate. An unusual pose that includes straight out arms and legs, downwards pointing toes, and arching of the head and ears. The muscles are tightened and rigidly held. This form of posturing typically means that there has been significant brain injury. So here is the signs of decelerate posturing. The head and the neck are arched, legs are straight, toes are pointed downwards, and arms are straight, extended, and hands are curled. Number 4. Decorticate. It is an unusual pose in which a person keeps his arms crossed, his fists clenched, and his legs straight. Backs are curved to the body, and thumbs and wrists are twisted to the chest. The arms are also bent. This kind of pose is a sign of significant brain injury. Medical care should be offered promptly to the individuals with this disorder. So the signs of decorticate posturing is that the hands are closed, legs are internally rotated, feet turned inward, and the arms are adducted and flexed against the chest. CLO number 2. Present the purpose of Glasgow Coma Scale assessment. It is used to objectively describe the extent of impaired consciousness in all types of acute medical and trauma patients. The scale measures the patients in 3 ways: eye opening, motor, and verbal reactions. CLO number 3. describe the different levels of consciousness. Number 1. Confused. Disoriented against the surroundings, may have poor judgment, and may require causes to respond to orders. Number 2. Lethargic. Sleepy, requires gentle verbal and contact stimulation to initiate reaction. Number 3. Obtunded. Slowly responds to external stimuli and requires regular stimulation to sustain concentration and reaction. Number 4. Stuporous. It responds only to minimally with rigorous stimulation and can only grant as a verbal response. And lastly, comatose. There is no detectable reaction to any external stimuli.
So, hi everyone, I am Abigail Magallanes and I will be discussing Objective 4 of Glasgow Coma Scale. Indications: neurologic injuries or disease process, such as stroke, brain tumor, and epilepsy, determine the severity of a brain injury. Altered loss of consciousness determine the severity of a brain injury. Metabolic imbalances, such as metabolic encephalopathy, determines the effect of neurologic signs and symptoms. Imbalances, such as metabolic encephalopathy, affects the brain and can lead to an altered mental state. Falls and trauma to the head determine the severity of a brain injury. Unresponsiveness determines the extent of impaired consciousness. Post-anesthesia determine the client's consciousness after surgery. Limitations: it is important that the total score is not reported without including all of the components because the score will be low and could cause confusion. Intellectual or neurological deficit. A client with neurological deficit can affect this GCS score due to limitations such as the inability to speak and abnormal reflexes. Hearing loss or speech impediment. A limitation since the client won't be able to hear the instructions given. A client with speech impediment can alter the GCS score under verbal response, making the total score lower. Effects of current treatment, such as physical and pharmacological effects. Physical, such as intubation. If a patient is intubated and unable to speak, they are evaluated only on the motor and eye-opening response, and the suffix T is added to their score to indicate intubation. In intubated patients, the maximum GCS score is 10T and the minimum score is 2T. As for pharmacological effects, such as sedation, if possible, the physician should obtain the score before sedating the patient. Effects of other injuries, such as orbital or cranial fracture, can affect the GCS score due to loss of speech or slurred speech caused by the injury. Spinal cord damage can affect the GCS score due to inability to move the arms or legs, feelings of spreading numbness or tingling in the extremities. Lastly, hypoxic ischemic encephalopathy after cold exposure can affect this GCS score due to motor impairment. Adult Glasgow Coma Scale. Eye response: eye open spontaneously, score of 4. Eye opening to verbal command, score of 3. Eye opening to pain, score of 2. No eye opening, score of 1. Verbal response: oriented, score of 5. Confused conversation but able to answer questions, score of 4. Inappropriate response, words discernible, score of 3. Incomprehensible sounds or speech, score of 2. No verbal response, score of 1. Motor response: obeys command for movement, score of 6. Purposeful movement to painful stimulus, the score of 5. Withdraws from pain, the score of 4. Abnormal or spastic flexion, the score of 3. Extensor rigid response, the score of 2. No motor response, the score of 1. Pediatric Glasgow Coma Scale. Eye response: children ages 1 year and above. Spontaneously, the score of 4. To verbal command, the score of 3. To pain, the score of 2. No response, the score of 1. Ages 1 years old and below, spontaneously, score of 4, to shout, score of 3, to pain, score of 2, no response, the score of 1. Motor response, ages 1 year and above, obeys command, 6, localizes pain, score of 5, flexion withdrawal, score of 4, abnormal flexion, score of 3, abnormal extension, score of 2, no response, score of 1. Ages 1 year and below, spontaneous movements, score of 6, localizes pain, score of 5, flexion withdrawal, score of 4, abnormal flexion, score of 3, abnormal extension, score of 2, no response, score of 1. Verbal response, for children 5 years old and above, oriented and converses, 5, disoriented and converses, score of 4, inappropriate words, score of 3, incomprehensible sounds, score of 2, no response, score of 1. For ages 2 to 5 years old, appropriate words and phrases, score of 5, inappropriate words, score of 4, cries or screams, score of 3, grunts, score of 2, no response, score of 1. For ages 0 to 23 months, coos and smiles appropriately, score of 5, cries, score of 4, inappropriate crying and screaming, score of 3, grunts, score of 2, no response, score of 1.
Good day, everyone. I am Andre Luis Lano, and I will be reporting to you today Cell 01 and Cell 02 of the cranial nerve assessment. So first, what is anosmia? So anosmia is an ability to smell or identify the correct scent. So it may be seen with lesions of the frontal lobe and may also occur with impaired blood flow to the middle cerebral artery. Next is hyposmia. So it is a reduced ability to smell and detect odors. Next is nausea. It is a general loss of ability to recognize objects through a particular sensory system. So it may be visual, tactile, or auditory. So the patient can also be shown a familiar object and asked to identify it by name. So inability to identify a visualized object is known as visual agnosia. Next is stereognosis. So stereognosis is the ability to identify an object by touch rather than sight. So the opposite of stereognosis is astereognosis. So this is the inability to identify objects by touch. Next is ptosis. Ptosis is also called Horner syndrome. So it occurs with strokes, myasthenia gravis, and palsy of the cranial nerve number 3. It is also the drooping of the upper eyelid. So lastly, nystagmus. So it is a rhythmic, oscillating, or also known shaking movement of the eye. So there are various movements. First is the horizontally, vertically, and lastly, rotary, as shown in the picture. Next is Cell O number 2, is to identify the purpose of the cranial nerve assessment. So first, it provides information regarding the transmission of motor and sensory messages, primarily to the head and neck. Next, it also helps to determine the cause of impairment and help the clinician begin to localize the problem. Next, it also assists clinicians in diagnosing illnesses as diverse as seizure disorder, narcolepsy, migraine disorder, dizziness, and dementia. Next, it detects dysfunctioning cranial nerves. Next, it formulates or helps confirm a diagnosis. Next, it assesses the client's sensory reception, which is the 5 senses: the sense of sight, sense of hearing, sense of touch, sense of smell, and sense of taste. Next, it assesses the client's overall motor function. And lastly, it assesses the overall reflexes of the client.
Good day everyone, this is Erica Tejano and I will be discussing cranial nerve assessment as to its indications, contraindications, and normal and abnormal findings, which is CLO number 3. So the indications for doing a cranial nerve assessment is during a routine physical examination, during a newborn physical examination, and to follow or assess the progression of a disease, following or assessing any type of birth defect or trauma to the head or spine, neurologic disorders, and if the client has any of the following complaints such as headaches, blurry vision, tinnitus, dizziness, alterations in hearing, sight, smell or taste, change in behavior, fatigue, difficulty speaking, difficulty swallowing, change in balance or coordination, numbness or tingling in the arms or legs, decrease in movement of the arms or legs, injury to the head, neck or back, temperature of unknown source, seizures, slurred speech, weakness, or tremor. So the contraindications for cranial nerve assessment is when the patient is unconscious, or when the patient does not give consent, or during situations wherein the test does not apply. So next are the normal and abnormal findings when assessing for the cranial nerves. The first cranial nerve is CN1 or the olfactory nerve. When assessing for the olfactory nerve, you ask the client to clear the nose to remove any mucus, then to close eyes, occlude one nostril, and identify a scented object that you are holding such as soap, coffee, or vanilla. Then you repeat this procedure for the other nostril. The normal finding for CN1 is when the client correctly identifies the scent presented to each nostril. We should also take note that some older clients' sense of smell may be decreased. Next are the abnormal findings for CN1. So, when the client is unable to smell or identify the correct scent, which is also known as neurogenic anosmia. So this may indicate olfactory tract lesion or tumor or lesion of the frontal lobe. It may be congenital or due to other causes such as nasal or sinus problems. It may also be caused by injury of nerve tissue at the top of the nose, and cocaine and smoking may also impair the sense of smell. The next cranial nerve is CN2 or the optic nerve. So to assess for the optic nerve, the first test is to assess or test the distant visual acuity. You use a Snellen or E chart to assess vision in each eye, and you position the client 20 feet from the chart. Normal findings would be when the client has 20/20 vision, and abnormal findings is when the client has difficulty reading the Snellen chart, missing letters, and squinting. Next is to test near visual acuity. You ask the client to read a newspaper or magazine paragraph to assess near vision. Let the patient hold the reading material 14 inches from the eyes and cover one eye with an opaque card. Normal finding is when the client reads at 14 inches without difficulty. Abnormal finding is when the client reads by holding closer than 14 inches or holds print further away, as in presbyopia, which occurs with aging. Next is to test visual field for gross peripheral vision. Assess visual fields for each eye by contemplation. Position yourself 2 feet away from the patient. Have the client cover his left eye while you cover your right eye. Slowly extend your left arm at midline and slowly move one finger upward from below until the client sees your finger. Normal findings. Full visual fields and the client can see the examiner's finger at the same time the examiner sees it. For abnormal findings, loss of visual fields may be seen in retinal damage or detachment, with lesions of the optic nerve or with lesions of the parietal cortex. Next is use an ophthalmoscope to view the retina and optic disc of each eye. For the normal finding for this is round reflex is present, optic disc is 1.5 millimeters, and then it is round or slightly oval, well-defined margins, creamy pink with paler physiologic cup, and retina is pink. For the abnormal findings, Papilla edema or swelling of the optic nerve results in blurred optic disc margins and dilated pulsating veins. Papilla edema occurs with increased intracranial pressure from intracranial hemorrhage or brain tumor. Optic atrophy occurs with the brain tumor. The next cranial nerves to assess are cranial nerves 3, which is also known as oculomotor, cranial nerve 4, which is also known as trochlear, and cranial nerve 6, which is also known as abducens. So first is to inspect the margins of the eyelids of each eye. The normal finding is that the eyelid covers about 2 millimeters of the iris, and then for abnormal findings, ptosis or drooping of the eyelid is seen with weak eye muscles such as in myasthenia gravis. Next, assess extraocular movements. So A. Corneal light reflex test is to check parallel alignment of the eyes. Hold the pen light 12 inches from the client's face and shine the light toward the bridge of the nose while the client stares ahead. B. The cover test. Ask the client to stare straight ahead and focus on a distant object. Cover one of the client's eyes with an opaque card and observe the uncovered eye for movement. Remove the card and observe the previously covered eye. C. Positions test. Instruct the client to focus on an object you are holding. Move the object through 6 cardinal positions of gaze in a clockwise direction. For the normal findings, eyes move in a smooth, coordinated motion in all directions. Abnormal findings, some abnormal eye movements and possible causes follow. First, nystagmus or rhythmic oscillation of the eyes, which may indicate cerebellar disorders. Next is limited eye movement through the 6 cardinal fields of gaze, which may indicate increased intracranial pressure. Last is paralytic strabismus, which may indicate paralysis of the oculomotor, trochlear, or abducens nerves. Next is to assess pupillary response to light and accommodation in both eyes. For pupillary, ask the client to focus on an object and shine a light into one eye. For accommodation, hold your finger or pencil 12 inches from the client's face. Ask your client to focus on it as you move it closer in towards the eyes. For normal findings, bilateral illuminated pupils constrict simultaneously, and pupils opposite to the one illuminated constrict simultaneously. For abnormal findings, a dilated pupil may indicate oculomotor paralysis. Constricted fixed pupils may indicate narcotics abuse or damage to the palms, and then unilaterally dilated pupil unresponsive to light may indicate damage to oculomotor nerve. The next cranial nerve to assess is CN5 or the trigeminal nerve. So next is to test the motor function. So ask the client to clench the teeth while you palpate the temporal and masseter muscles for contraction. For normal findings, temporal and masseter muscles contract bilaterally. For abnormal findings, decreased contraction in one or both sides. Asymmetric strength in moving the jaw may be seen with lesion or injury. Pain occurs with clenching of the teeth. Next, for sensory function test, touch the client's forehead, cheeks, and chin with the sharp or dull side of a paperclip. Instruct the patient to identify if he feels a dull or sharp sensation and where he feels it. Repeat it with a wisp of cotton. For normal findings, the client correctly identifies sharp and dull stimuli and light touch to the forehead, cheeks, and chin. For abnormal findings, inability to feel and correctly identify facial stimuli. Next is to test the corneal reflex. Ask the client to look away and up while you lightly touch the cornea with a fine wisp of cotton. Repeat on the other side. This reflex may be absent or reduced in clients who wear contact lenses. So for normal findings, eyelids blink bilaterally. For abnormal findings, an absent corneal reflex may be noted with lesions of the trigeminal nerve or lesions of the motor part of the cranial nerve number 7, which is the facial nerve. The next cranial nerve is cranial nerve number 7, which is also known as the facial nerve. So to test for motor function, ask the client to smile, frown, and wrinkle forehead, show teeth, puff out cheeks, purse lips, raise eyebrows, close eyes slightly against resistance. So normal findings for this test is that the client smiles, frowns, wrinkles forehead, shows teeth, puffs out cheeks, purses lips, raises eyebrow, and closes eyes against resistance, and movements are symmetric. For abnormal findings, Bell's palsy or the inability to close eyes, wrinkles forehead, or raise forehead along with paralysis of the lower part of the face on the affected side. So paralysis of the lower part of the face on the opposite side affected may be seen with central lesion that affects the upper motor neurons, such as from stroke. The sensory function of cranial nerve number 7 is not routinely tested, but if indicated, touch the anterior 2/3 of the tongue with a moistened applicator dipped in salt, sugar, or lemon juice, and ask the client to identify the flavor. So the normal finding is that the client identifies the correct flavor, and you should also take note in some older clients the sense of taste may be decreased. For abnormal findings, inability to identify correct flavor on anterior 2/3 of the tongue suggests impairment of the cranial nerve number 7 or the facial nerve. The next nerve is cranial nerve number 8 or the acoustic or vestibulocochlear nerve. So to test the client's hearing ability in each ear, perform the Weber and Rins test to assess the cochlear or auditory component of the cranial nerve number 8. So the normal finding for this is that the client hears whispered words from 1 to 2 feet. The Weber test helps evaluate the conduction of sound waves through bone to help distinguish between conductive hearing, which is sound waves transmitted by external and middle ear, and sensory neural hearing, which is hearing in the inner ear. So to do this, you strike a tuning fork softly with the back of your hand and place it at the center of the client's forehead or head, and then ask whether the client hears the sound better in one ear or the same in both ears. So the normal findings for the Weber test is that the vibration is heard equally well in both ears. For abnormal findings, vibratory sound lateralizes into good ear in sensory neural loss. If it is in the bad ear, it is a conductive hearing loss. The Rins test is a test for air and bone conduction. To do this, strike a tuning fork and place the base of the fork on the client's mastoid process. Ask the client to tell you when the sound is no longer heard, and move the prongs of the tuning fork to the front of the external auditory canal. The vestibular component responsible for equilibrium is not routinely tested. In comatose clients, the test is used to determine integrity of the vestibular system. So the normal findings for the Rins test is that air conduction is twice as long as bone conduction. So air conduction is greater than bone conduction. For abnormal findings, air conduction is longer than bone conduction, but not twice as long in a sensory neural loss. So the next nerve to assess is cranial nerve 9, which is also known as glossopharyngeal nerve, and cranial nerve 10, which is also known as the vagus nerve. So to assess for motor function, ask the client to open mouth wide and say ah while you use a tongue depressor on the client's tongue. Normal findings is that the uvula and the soft palate rise bilaterally. For abnormal findings, soft palate does not rise with bilateral lesions of the cranial nerve 10 or the vagus nerve. Next is test the gag reflex by touching the posterior pharynx with the tongue depressor. You should warn the client that you are going to do this and that the test may feel a little bit uncomfortable. So the normal findings is that the gag reflex is intact. Some normal clients may have a reduced absent gag reflex. In abnormal findings, absent gag reflex may be seen with lesions of cranial nerve 9 and 10. Next is to check the client's ability to swallow by giving the client a drink of water. Also note the client's voice quality. So the normal findings is that the client swallows without difficulty and no hoarseness is noted. Abnormal findings, there is dysphagia, which is also known as difficulty swallowing or hoarseness, may indicate a lesion of cranial nerve 9 or cranial nerve 10 or other neurologic disorder. The next cranial nerve to assess is cranial nerve 11 or the spinal accessory. First, ask the client to shrug the shoulders against resistance to assess the trapezius muscles. Normal findings is that there is a symmetrical and strong contraction of the trapezius muscle. Abnormal findings, weak or absent shoulder shrug and inability to turn the head to the side may be seen with paralysis or muscle weakness. Next, ask the client to turn the head against resistance, first to the right then to the left, to assess the sternocleidomastoid muscle. Normal findings, strong contraction of the sternocleidomastoid. For abnormal findings, atrophy with fasciculations may be seen with peripheral nerve disease. The last cranial nerve to assess is cranial nerve 12, which is also known as the hypoglossal nerve. To assess strength and mobility of the tongue, ask the client to protrude the tongue, move it to each side against the resistance of a tongue depressor, and then put it back in the mouth. Normal findings is that the tongue movement is symmetric and smooth and bilateral strength is apparent. Abnormal findings, fasciculations and atrophy of the tongue may be seen with peripheral nerve damage or disease. So that is all for our report and thank you for listening. Ang kabut